Upper tract urothelial cancer is also known as UTUC, and this is the upper urinary tract as opposed to the bladder and the urethra coming to the outside world through the penis. And it's a really neglected area. There's a number of reasons for this. First of all, because it's a low incidence tumour. So in the UK every year there are probably about 1,400 new cases. Despite that though, it is a more lethal cancer than its sister tumour, bladder cancer, with whom it shares many similarities pathologically. Similarities, but they're not the same beast, because stage for stage UTUC patients tend to have a higher rate of relapse, of distant metastases, and their overall prognosis is poorer than transitional cell carcinoma of the bladder. And it's been a really neglected area for a number of reasons in research. First of all, bladder cancer itself is very neglected and overlooked. If we look at funding into bladder cancer research, it's much less than things like colorectal cancer, breast cancer, and in fact, it's less than 0.1% in the UK of funding from NIHR partners. And if you think that UTUC is a section of bladder cancer overall, that group of tumours, then you can see why it's been overlooked. There's only been one previous randomised controlled trial in UTUC, and this was called the ODMIT-C study, which is again a UK-led study by Tim O'Brien and his group from London, which looked at patients who'd had a radical nephroureterectomy, which is the standard surgical treatment for an upper tract urothelial carcinoma. And if you gave a single dose of intravesical mitomycin C into the bladder, did it reduce the rate of recurrence of bladder tumours subsequent to nephroureterectomy? And that's the only other randomised trial we've ever had. And that isn't a study really of intravenous systemic therapy or a study of advanced disease in UTUC. So there's been an absolute paucity of data to try and guide practice. So it's been overlooked because no one's been particularly interested in it. It's a low incidence but high lethality tumour for the more advanced stages. So POUT actually stands for perioperative chemotherapy or surveillance in completely resected upper tract urothelial carcinoma. And we had the idea for this study because of the unmet need in this area and the lack of data really. So the standard treatment for patients who present with what is thought to be an upper tract tumour is a radical en bloc nephroureterectomy. Now the diagnosis of an upper tract tumour is actually in itself fraught with difficulty. In the UK, when we look at the British Association of Urological Surgeons database and you look at the time from patients presenting with symptoms to their definitive treatment, which would be surgical, the average delay is about 167 days. And that's because there are difficulties in obtaining a definitive histological confirmation of cancer. Some of these you can see very little on a scan. It might just be that you have a bit of a narrowing of the ureter, the tube draining from the bladder to the bladder down from the kidney, or you might have a patient, usually they present with hematuria, with blood in the urine. So there are a lot of diagnostic delays for many of these patients. And we originally looked at whether we should have a neoadjuvant or an adjuvant study. And we looked at this from a clinician viewpoint and from a patient viewpoint. From the clinician viewpoint, we did a survey across the UK which said if we were looking at developing a study, which of these two approaches would you favour? We're going back in time now to about 2010, and at the time the majority of oncologists in the UK said they were uncomfortable giving systemic chemotherapy based on no definitive pathological confirmation of tumour. And so we decided that from a clinician viewpoint we would look at an adjuvant study. From the patient viewpoint, when we were looking at setting up POUT, before we ever went for funding, we advertised for patients to take part in 2 focus groups, and we did this through the Macmillan Voices website and through patient contacts for some of the clinicians that came together to help me to form part of the original protocol development group. And we talked to the patients about what a trial might look like, and again the patient's steer was that they would want to know that they had definitive cancer before they moved on to any form of chemotherapy, and that was why we went with an adjuvant study at that time. Now, this was slightly against the information we had in bladder cancer at the time, where we know that giving neoadjuvant chemotherapy in bladder cancer is the right thing to do. It improves survival by 5%, overall survival at 5 years. But because of this diagnostic uncertainty, the clinician preference and the patient preference, we went with an adjuvant study, and that was how POUT was born. What POUT looks at is trying to determine what is the right action after a radical en bloc nephroureterectomy for patients who have adverse features. So by that I would define it as locally advanced disease, so that would be pathologically T2, T3 or T4 tumours and N0, or they could be node positive, so N1, N2 or N3, as long as if those nodes had been seen on a preoperative CT scan, they were removed at the time of surgery, and then the patient had a negative post-operative CT. And again, if the patient had nodes that were seen at all before surgery, they must have a negative post-operative CT scan. And there are a number of other criteria that we needed for the study in terms of fitness for chemotherapy, renal function, etc. So the other option would be surveillance, and we did a survey again across the UK before we ever went for funding to see what people's current practice was, and at that time it was about 65-35%, so about 65% of UK oncologists would offer patients surveillance as the standard of care, and about 35% would offer in selected patients adjuvant chemotherapy of some sort on a case-by-case basis. But everybody said that we don't know if what we're doing is right, and we'd really love a trial, and we'd be more than happy to sign up for a study, which is what you need for something where you have a low incidence tumour, is you need lots and lots of sites to be able to recruit all the patients that you need. And that's really how the trial was born, and that's how we decided between the whole neoadjuvant and adjuvant thing. It wasn't just a cavalier decision at the time. If we look at where we are now, 2019, with the trial shut, we still have this discussions at conferences whether adjuvant was the right thing to do or neoadjuvant. And I reflect back and say, well, these were the reasons why we did it at the time. We still have diagnostic uncertainty about these patients preoperatively. Even in the best of hands with positive cytology and trying to get a biopsy beforehand, you can't necessarily say for 100% that that patient has advanced cancer before you do the surgery. And in fact, when we look at the results of the POUT study, there are obviously a number of patients that were ineligible for the study, who we thought preoperatively would probably be eligible, and their reason for being ineligible was that they had PT1 tumours rather than PT2 tumours. So there is still that diagnostic uncertainty, and the outcome for PT1 tumours is so much better. So there's the concern, if you gave them neoadjuvant treatment, that you would be over-treating a group of patients who are going to do well anyway. So we don't currently have 100% certainty to be able to give neoadjuvant treatment. I think there's also some mix-up in terminology. So some people use the term neoadjuvant as a blanket term. Now, if we've got somebody with a really big bulky tumour on a CT scan with obvious nodal disease, that patient is probably not operable. So you're not giving them neoadjuvant treatment, you're giving them downstaging chemotherapy to then potentially render them operable. But some people use those terms interchangeably, so that's another reason for confusion. The POUT trial is a study of adjuvant chemotherapy versus surveillance in T2 to T4, N0 to N3, providing those nodes are being resected, upper tract urothelial cancer. And obviously the patients have to have those pathological characteristics, and then patients are randomised on a one-to-one basis to either 4 cycles of chemotherapy or to surveillance. It's really important that we look at the chemotherapy type, and this was stratified only by renal function, by GFR. So if a patient had a creatinine clearance of greater than 50, so that's quite permissive. So if you look at most other studies of agents in urothelial cancers where you're giving cisplatin, the cutoff is a GFR over 60. Now, those of us that treat these patients every day have been using a GFR in real life practice of down to 50. We're all comfortable with that, and some centres use a GFR down to 40, and then they fractionate the cisplatin on day 1 and day 8. So we're all very comfortable in real life. So POUT was a very pragmatic design from the outset because of the low incidence tumour. You have to have a pragmatic design. POUT opened to recruitment in May 2012 and then closed to recruitment in November 2017, and it actually shut prematurely, not for any safety reasons, but because, as with any study, we have an independent data monitoring committee who look at the results. And the original primary endpoint of the study was quite an ambitious endpoint. We were looking at a potential 15% difference between the two groups in disease-free survival at 3 years. And when we had the alert from the Independent Data Monitoring Committee, it was to say that we'd met our primary endpoint. In fact, what we had done is we'd met it a year earlier, so it was looking at 2-year disease-free survival, and there was a 17% difference between the two groups in favour of chemotherapy. So the number of patients who were disease-free at 2 years in the chemotherapy group was 71%, and the number of patients who were disease-free at 2 years in the surveillance group was 54%. That difference was seen across all of the subgroups. Obviously, in some of the subgroups we had smaller numbers, so in terms of the patients who had positive margins or positive nodes, there were fewer patients, and there were fewer patients having carboplatin rather than cisplatin. But if you actually look at what's called the test for interaction, that is negative across all of the subgroups, and so we've no reason to believe that the treatment effect is different in any of the subgroups. So the treatment effect stands across all of our subgroups, irrespective of nodal status, T stage of the tumour, whether it's T2, T3, T4, and chemotherapy type. So it's a positive study with a hazard ratio of 0.49. We have the same results for metastasis-free survival, again at 2 years in favour of chemotherapy, and that is 74% of patients were metastasis-free in the chemotherapy group compared to 60% in the surveillance group. At the moment, we're still collecting data for overall survival, so that data is immature at the moment. There is a trend to an improvement in overall survival, but obviously things can change and we can't apply any formal statistical constraints towards that, and that data collection is ongoing. So that's very exciting data. First study in this area, first randomised trial ever. It's a positive study, it's practice changing in favour of adjuvant chemotherapy, and it's a triumph of the UK pulling together. We had 75 sites open across the UK, of which at least 57 of them recruited at least one patient. So the sites are open across the length and the breadth of the UK, and it's a real triumph of what we can do here. We now have level 1 data to say that we should be using adjuvant chemotherapy for these patients. That chemotherapy should be stratified by renal function. Now, in real life, obviously, once you're familiar with doing something just merely based on the trial data, we all tend to often expand the group of patients that we would potentially look at treating. So if I saw a patient who was otherwise fit but say had tinnitus that I didn't want to give cisplatin to, I would give them gemcitabine carboplatin. Although they were not in the trial population, they would have been excluded from the POUT trial population because of their tinnitus. However, I would give them gemcitabine and carboplatin. I think we've got level 1 data to say that patients who have got T2 to T4 disease or node positive disease that's been resected with upper tract urothelial carcinoma, who are otherwise fit for treatment, should now receive, as part of standard of care, 4 cycles of chemotherapy, and that should be gemcitabine cisplatin, ideally if they fit all the criteria for that, and otherwise based on GFR really, or tinnitus, I think they should have gemcitabine carboplatin. In fact, when we're looking at the successor study, we have looked at tinnitus patients being included in the study potentially, rather than being excluded just because they couldn't have cisplatin. But that should really now be part of standard of care, and once the manuscript has been presented, I know that we're looking at that being incorporated into European guidelines. The previous EAU guidelines just said we're waiting for the POUT trial data. And that is still the only level 1 data that we have. There is some phase 2 data of 30 patients having neoadjuvant chemotherapy that has just shown some downstaging. So what are you going to do? You're going to go with your level 1 data with this, really. If we look at the POUT group of patients, so those 261 patients that went into the trial, all of the patients that got chemotherapy, all of the subgroups benefited. So T2, T3, T4 disease, node positive, node negative, margin positive, margin negative, even though some of those subgroups are too small to meet statistical significance because of the numbers of patients. However, we know that p-values are really not what it's all about. If we look at the STAMPEDE data and look at the subgroups in STAMPEDE, where you've got fantastic results in terms of reduction in risk of prostate cancer death and improvements in disease-free survival, but no improvements in overall survival from a statistical viewpoint. There's very erudite articles written by Matt Sides about the p-significance and looking at subgroups, and I think exactly the same applies to any study where you have pre-planned subgroups. So those are the patients that we should be treating, and the patients that we shouldn't be treating are the patients that didn't go into POUT, and the main reason for ineligibility was pathological ineligibility, and that was patients with PT1 disease. Those patients' prognosis is so much better. They just need to have surgery, and then they're done, and they just have follow-up. There are obviously another group of patients who've got huge tumours, who've got inoperable, advanced upper tract urothelial tumours, big nodal mass. You're going to have difficulty getting it out. They should have downstaging chemotherapy, and then, so it's not neoadjuvant. They should have downstaging chemotherapy and then move on to their definitive surgery if you've managed to shrink the original mass enough to then move on to surgery. If we look at current checkpoint inhibitor studies, ones that are awaiting reporting at the moment, we have a number of those. We have 2 adjuvant studies after cystectomy, so that's a different patient group, and we have some first-line metastatic studies which are comparing combination chemotherapy with immune oncology agents or IOs versus IO alone versus chemotherapy alone, and all those studies are currently close to recruitment, and we're waiting the data with interest. So there is no study at the moment comparing chemotherapy with chemotherapy plus IO. The adjuvant studies were surveillance versus IO. They were just cystectomy. So the studies that we have at the moment, in the adjuvant studies, there was a protocol modification because originally those 2 studies, one with atezolizumab and one with nivolumab, because they were recruiting fairly poorly because cystectomy is a more morbid operation, so they allowed a protocol amendment to have up to 10% of patients with upper tract urothelial cancers who've had a nephroureterectomy to go into those studies. Now, because the POUT was still recruiting, the UK didn't participate in those studies because it was a competitor study. And so they did a protocol amendment. They didn't set off with a properly powered study to answer the question, do checkpoint inhibitors improve the outcome for patients with upper tract cancers after nephroureterectomy as their main objective. So this has been added on after just to try and boost the patient numbers in the study. So those will be underpowered subgroups, unable to answer the question definitively. Now, checkpoint inhibitors are interesting in upper tract tumours because upper tract tumours they're not bladder cancers. They have similarities with bladder cancer, but they have pathological differences, and they have clinical differences in terms of their outcome to bladder cancer. So they have a high rate of microsatellite instability, so checkpoint inhibitors are intrinsically more interesting. And that's one of the reasons why at the moment we're in advanced discussions about a successor study to POUT, which we have imaginatively called POUT2. And we have contacted our original POUT centres, the 75 centres across the UK. We've contacted a number of European centres and centres across the world to sort of see what their interest is in this, and that would be looking at combination versus standard of care, which is obviously now chemotherapy. When you've already got the answer to chemotherapy, then any other study is going to be proportionately need more patients than we had to answer the question, because the magnitude of benefit is also likely to be smaller as well, which is why we've gone out to international collaboration. I think the really exciting thing in the last couple of years for urothelial cancers across the board has been that we are moving from the era of just saying this is a transitional cell carcinoma to breaking it down into far more subgroups. So we have data particularly from the TCGA and from Lund where they've looked at all of so we have 7 effective different types of bladder cancer now from urothelial cancer, and it's likely that some of those cancers are more sensitive to immunotherapy and checkpoint inhibitors. Some of them are more chemotherapy sensitive. At the moment we're starting to do ongoing trials based on that profiling to try and determine what is the best treatment for those patients. There are going to be some very exciting studies where, which are going to be difficult to recruit to based on these pathological subtypes, where we'll be saying to patients that the data we have so far says that we think you're probably not going to respond perhaps to neoadjuvant chemotherapy, so we'll go straight on to cystectomy. Those are going to be quite difficult to consent patients to. But those are the studies that we really should be doing. In bladder cancer, looking at radiotherapy, we have a lot of work's been done by my colleagues, particularly Anne Kilty, Catherine West and Anya Chowdhury, Peter Hoskin, looking at the prognostic and predictive markers for patients who may respond better to radiotherapy, looking at things like hypoxia modification from the patients in Beacon, and looking at the BC 2001 patients who had chemoradiation added in, well, chemotherapy added into their radiotherapy. So that data is going to be coming out, and has already, some of it's been presented at ASCO GU a week or 2 ago, and those will all need to be validated. So it would be fantastic if we were able to say to a patient, I think you should definitely have radiotherapy because you show all the right characteristics to benefit from that, and if we add in drug X, then that will have, I can show you for your tumour type that is definitely going to benefit you. I think that's going to be, that personalised medicine is going to be the way forward over the next few years. It's fantastic, isn't it, that we've had, bladder cancer, Cinderella cancer, nobody was interested, nobody cared, we got no funding. We've now got a bit more funding. It's still a relatively tiny piece of the pie, which is iniquitous, because bladder cancer is by far and above a hugely expensive and the most expensive cancer to treat in terms of resource, because 70% of bladder cancer is non-muscle invasive bladder cancer, and for those patients they have repeated invasive investigations with cystoscopies and follow-up. We don't at the moment have a non-invasive test that's better than cystoscopy. So it costs a lot of money, it costs lots of patients' anxiety, and yet it's not, hasn't reached any of the healthcare priorities, which is iniquitous really. So we need better tests. There's exciting work going on for non-invasive tests, and there's been 2 separate platforms looked at urinary tests to see if you can diagnose non-invasive bladder cancer from a urine test rather than just having to do a cystoscopy. So that would be great for patients if we were able to do that. I think we've got all of these new checkpoint inhibitors that are now we use day in, day out in bladder cancer. We're going to be looking at combinations of those. Obviously those only work for 1 in 5 patients, so they aren't a universal panacea, and a lot of the time I think with immune oncology agents, because they're new, they must be better. They have got less side effects than standard chemotherapy, but we need to make certain everyone knows how to manage those side effects in the 10% of patients where they get severe side effects. And there are newer drugs coming through as well. So patients with advanced bladder cancer, some of them express the FGFR receptor 3, and that's another target for probably about, again, about 20% of bladder cancer patients. So it's fantastic that the pharmaceutical industry has worked with us to help develop a lot of these molecules, and we have got options for patients now. But if you think about it, for advanced bladder cancer in the UK, the prognosis has not improved over the last 20 years. The incidence has gone down, but the mortality hasn't improved. So we've not been doing any better. So that's why we have to really do better.